My name is Liz. I'm a member of the clinical education team. This set of notes that we're going to be looking at now are specific to prescribers in the outpatient setting. That can be a psychiatrist, a prescribing psychologist, a nurse practitioner, or a physician assistant. I'm starting in the chart room and I've already typed in the name of my brand new patient. I'm going to click this icon right here to go to her chart face. She's a brand new patient. I don't have any notes in here. I don't have any information about her other than a picture of her right up here that I've uploaded and dropped into her Documents tab. Okay, we're going to come down here, and the first note for the complete evaluation for a prescriber is the complete assessment of your discipline. It's this lavender button here. The program's going to recognize when you click on this, whether you're logged in as a doctor, a nurse, or a social worker. Prescribing clinicians, like I said, medical doctors, prescribing psychologists, nurse practitioners, medical doctors, are all come under the heading of prescriber, and you can all document for evaluation and management coding. We're going to be talking about E&M coding as we go through each type of note. The workflow on ICANotes is left to right across each of these tabs and across each page of the program with a top to bottom, top to bottom, top to bottom workflow. You'll notice here that before the adult patient, we are prompted to put in a chief complaint in the patient's own words. This is a Medicare requirement, and ICANotes is compliant with Medicare. It's one of the few times in the program when you must type in a full sentence. The patient says, "I'm so depressed since my twin sister committed suicide." We're going to come over here. The gray areas have the hardwired buttons. If you're not familiar with how to work in the basics of ICANotes, I recommend that you go back to the first 5 basic training videos at the top of the list on our website. We're going to talk about the patient having symptoms of, and her first problem is that she's depressed. So I'm going to come down here and go into the depression shrub. For prescribing clinicians, there's an algorithm that's working behind the scenes that's capturing data that you enter under your history of present illness, under the depression shrub, and under the level of complexity. So let's come down here and capture some good information. Information was received from, I'm going to say, the patient, and it puts down Snow's name. History, this is the who, what, when, where, and why of her depression. Prescribers, please fill out all of these areas so you get maximum coding credit. Is there a precipitant for her depression? Yes. As a matter of fact, she did describe one. It has to do with the death of an important person in her family, I guess. And I'm going to come down here and put down what is the speed of onset, and she says that it's been rapid over the past couple of days. Let's say sister committed suicide last weekend. When depression occurs, she says it's episodic, it's happening daily, and it's lasting for several hours at a time. Has this lady ever been depressed before this event? And she says nope. She's never been manic before this event. What current symptoms is she having? We're working in an outpatient setting here. I'm going to say that she's having some anhedonia and anergia and anhedonia, a difficulty concentrating. She feels guilty. And I could also say that she's having feelings of worthlessness. Let's come down here and talk about suicide. And I'm going to say that this lady is not suicidal. Let's go back to our History of Present Illness tab. We've documented under depression. We get a red X here, meaning that we've already worked in this area. In terms of evaluation and management coding, we've picked up 4 credits for the who, what, when, where, and why of our depression. If she also had anxiety, we could come up here and talk about that. Let's work through here very quickly. I'm going to click on the anxiety button. She does have anxiety symptoms, and the onset of that has been for years. So this precedes her depression. What symptoms does she have? We give you a nice long list of symptoms, but she only endorses one, so you only have to click one. She describes an exaggerated startle response right here. Startle response. How often does she have that? She says it happens a few times a week. When did she last have this? She says, let me see here. prior episodes. She's had previous prior episodes. We'll just leave it at that. And the severity and complexity of this, she says, it's moderately bothersome to her. Okay. I just want to draw your attention to the fact that if your patient does have anxiety, but it's a specific type of anxiety, for example, PTSD, instead of going into the general anxiety area, you could come down here to PTSD. We'll just skip down and look at the symptoms relative to this, and they're going to be specific to PTSD symptoms: diminished interest, dreams, flashbacks, feelings of detachment, irritability, or anger. Great. Notice that when I click this button, it entered a sentence into the program. I don't need that sentence. I'm going to highlight, right-click, and cut it out, and away it goes. I'm done discussing anxiety, so I'm going to go back to my history of present illness. And notice that I've worked in 2 areas, and I've put down that the patient, under my depression field, I put down that the patient had a moderate level of complexity, so that's been documented already. To go down further and to grab further documentation credit under the history of present illness, the psychiatrist, please stay away from these denies buttons. You're not going to pick up coding credit by using these buttons, so don't go there. Rather, come over here and do a problem pertinent review of other psychiatric symptoms. You need to click on at least one. I'm going to say, of course, she's got the anxiety. She's got depression. I'm going to say she denies mania and she denies OCD. You can see here that it's given us credit for a problem pertinent review of systems, saying she specifically denies both of those areas. If you want to drill down further, and this is more for the inpatient setting, but in the outpatient setting, sometimes it's important to do, you can say that the constitutional system is normal and the musculoskeletal system is normal. I'm going to skip these for right now, but I do want to take you in here and show you a detailed review of other body systems. So let's say that this lady presents with depression and she also has hypothyroidism, and you think that that's a big contribution to her depression today. You don't want to hide it just in the medical history. You kind of want it out here, out in front in the HPI. So we're going to come down here, and these are all other body systems alphabetized. It's really easy. I'm going to come down here and look for the endocrine system. Click. I'm going to say there's an endocrine abnormality noted, and it has to do with her thyroid, and I'm going to say she has hypothyroidism, and that otherwise her endocrine system is negative. And I could go down here and put down as many positive or negative body systems as I want to. I am going to pick up a little bit of extra coding credit here for doing that. Okay, we're going to talk about entering test results in ICANotes also, where we're on the history of present illness page. If you've ordered labs and they come back completely normal, I recommend that you upload them onto your desktop, or you scan them into your desktop and upload them onto ICANotes and drop them into the documents folder. There will be a video training on that moving forward. But if you have labs that you want to trend over time, or that are abnormal labs, or the patients maybe having some drug levels that you want to trend, you might want to come in here and add them. They'll show up not only in your narrative, but they'll be saved into the log area, and you'll be able to trend those results over time. So let's enter some test results here. We're going to enter 2. When I click New, all it does is put down today's date, but I could backdate if this was drawn yesterday, for example. I want to come down here and do a chemistry level. Let's say she had a lithium level drawn yesterday. And I'm going to drill down here till I find lithium level. Let's say that her level was 0.7. And I'm going to go ahead and save this. It saves right up here. And then I can come over here and add another lab. Let's say her platelet level is low. And this was drawn maybe last week on Friday the 4th. So I'm going to change the date of that. And I'm going to come down here to hematology. And I'm going to slide my way down to platelet count. And let's say she's at 100. We don't have 125,000, but you could easily erase a 0, put 125,000 in. Save that. And now you have 2 labs. You can enter as many abnormal labs in here as you'd like to. I'm going to just save these 2 areas. They're done. Let's go back. Let's scroll down. We're still in our history of present illness. And you can see my test results or my lab results right here. Next, we're going to move over to the past psychiatric history. For you prescribers, there's probably not a whole lot here that's new or different, but in terms of E&M coding, you have to put something in each of the history areas, even if you put down that it's negative, foreign adult, or that you're unable to get this information from the patient. Medicare, Medicaid says they're not asking you for specific details here. They just want you to push in something under each of these history areas. Different from your HPI and different from your mental status exam. If you're doing the first complete evaluation on your patient, you're going to have a brand new page right here. We're going to come down and I'm going to pick out just a couple of areas. Has this patient ever been hospitalized before? And I'm going to say, nope, never. Has a patient been treated in the outpatient setting? She says, nope, never have. Any history of assault? And she says, that's never happened to me. I've never been assaulted either. We've got a little bit of past psychiatric history. I'm going to backtrack for just a minute to the history of present illness. One thing we didn't discuss is that if this were a follow-up complete evaluation, if either yourself or a medical doctor or a nurse or a therapist had done some sort of a complete evaluation for Snow White in the past, when you go forward into your past psych history, your medical history, social history, family mental health history, that prior information is going to be pushed out for you automatically. So I'm going to kind of pretend that we've done this, even though this is our very first virgin complete evaluation. Let's go into the past psychiatric history and see what it might look like if somebody else has already worked in here prior. And I have a psychiatric hospitalization, the outpatient treatment and assaultive behavior has all been denied. Now, if you don't want to keep this information in your complete evaluation, you are free to erase it. However, sometimes it's helpful to know that the patient is giving a different history to different members of the team, or that the past psychiatric history has changed since the last time you performed this on a patient. A nice way to do this is to use a custom button. I'm going to use an addendum button here. I've made this on each area, on each history tab. It's very easy to use. It says Addendum Snow, our patient, has described the following pertinent information with me today. So I'm going to come down here and say substance abuse. She says she has no history of it. She denies. Medication compliance. She says she does have a history of noncompliance, and she has been on a psychotropic medication in the past. And as a matter of fact, that happened to be, let's go with Buspar, for example, maybe for her anxiety. All psychotropic medications are here from Abilify through Zyprexa. I can come over to the third column and I can detail as a prescribing clinician how she tolerated the Buspar if she shares that with me. Maybe she says, oh, I stopped taking that. It was expensive and I don't believe in psychiatric medications and I haven't taken that medication for over a year. Or likewise, she could say, oh, yes, I've been taking that for several years and the current dose is 15 milligrams, I could pop that in, and it's been very effective for me or just partially effective for me. You can detail each psychotropic medication individually. I do want to show you that we have an area here that's new, relatively new to the program, and it's a way to document injectable medications. It's right down here, injectables. So if your patient, for example, is getting Invega Cisterna 78 milligrams every 2 weeks, you can click this button. Invega Cisterna 78 milligrams, Q2 weeks. And you can even put down that the patient is compliant with that if you'd like to, using a custom button. We'll talk about how to make custom buttons in a future training video. Does this patient have a history of failed monotherapy? I'm going to say no, she doesn't. And you can talk about prior psychiatric disorders, prior care settings, and say otherwise your psychiatric history is negative. We're going to move over here to the medical history. This is going to go pretty fast for us. We're going to come over here. If your patient, inpatient or outpatient, it doesn't matter, is positive for MRSA or positive for HIV and you want to capture that, let's go down here and look at infection or disease right here at the top. We start off with tuberculosis and we have other infections or contagious diseases. Lots of options here. I'm going to say she's positive for MRSA. I'm just going to click that in. There is a recent or new infection with MRSA. Details are as follows. And I'm going to use a custom button here to shortcut this. She remains positive after a 3-month treatment with vancomycin. We can talk about her past medical and surgical history. We can talk about adverse drug reactions. Adverse drug reactions are just that. The patient is not tolerating a specific drug and you need to document that. So I'm going to come in here to the list of adverse drug reactions and take you through this. This is a very important area. It's very nice to get this documented into the first complete evaluation. It doesn't matter if you're a doctor or a nurse that is doing this. This information will push out to the chart face and into your MAR as well. I'm going to click New. The workflow is going to be top to bottom and a left to right, and I'm going to say she has an adverse drug reaction. Let's just say to sulfa drugs. If you don't see the drug on here she's allergic to, feel free to type it in. Don't worry about this information. The status of this drug by default is active. You have to put a reaction date. Let's say she says, oh, this happened to me about 5 years ago. This is a little trick I like to use. I put down 12/14 of 2015, and I just take off the 5 and I turn it into a 2010. Or if that's not good, maybe this happened to her, she doesn't know when it happened, or it happened during childhood. You can click unknown, but you do have to make a choice here under number 3. So what happened when she took sulfa drugs? Let's say that she had a respiratory event, that she had respiratory distress, and I have a button over here that says that occurred during childhood. I'm going to go ahead and save this event. It's added. Sulfa drugs, respiratory event, occurred during childhood. And let's go back. Okay, here's your adverse drug reaction. It has immediately pushed out to the medication area, like I told you. If somebody else, another prescriber, was working in Snow White's chart right now while you're documenting this information and tried to order a sulfa drug, they would immediately receive a warning that says, hey, she's had an ADR to that. Do you want to override that in Prescriber, or would you like to prescribe something else? Okay. Let's come down here and look at allergies. In ICANotes, allergies are food allergies. Let's say peanuts causes hives, for example. We can talk about compliance for non-psychotropic medications. I'm going to say that she's generally been compliant with those. Current medical diagnosis, let's just go with one, cardiovascular. All the body systems are alphabetized, very easy. I'm going to come over here, look for hypertension. Bing, there I have it. If I want to talk about what medications she's taking current to her cardiovascular hypertension, I'm going to come over here and select cardiovascular again. I'm going to come down here and say maybe she's taking Lasix. Most of us know that patients that are on Lasix are generally on a potassium supplement. I'm going to use a custom button to just pop that information right in. Okay, let's come down here. You can talk about reproductive history, especially important in a female patient of reproductive years. There's a lot of GYN information you can capture here, but pregnancy is about halfway down the list, and I'm just going to say that she's not pregnant, but otherwise you can detail it if you'd like to. We have health and behaviors and tobacco and hearing and vision. I am going to take you into the pain scale. I think that a lot of you probably have patients who have acute or chronic pain. Let's say that Snow has low back pain. Maybe she was in an automobile accident. Let's see how fast we can put this in. She's got current pain. The location, she says, is in her lower back. The timing of the pain, she says, is after exertion. The quality of the pain, she describes this as a sharp pain. Frequency and duration, she says it happens several times a day and it lasts for several minutes when she feels it. It's worsened by certain positions. It's relieved by, she says she's tried acupuncture, but it's not helping too much. She's also tried TENS unit. That's not helping either. We asked her if her pain's controlled and she said no, it's not really under good control. On a scale of 1 to 10, with 10 being your worst pain, how would you describe the pain? She says, I'd call it a 5. So you can see how quickly we were able to put this information in one time and move forward. The other area that I'd like to show you in the medical history for prescribers is this cardiac disclaimer. It's important. There's no family history of early death due to cardiac arrhythmia or conduction defect or other related cardiac issues. Okay, let's move over here to the social history. So as prescribers, depending on whether you have a social worker in your office or not, or you have a nurse in your office that maybe is capturing some of this information for you, we have some opening sentences. Snow is a married 60-year-old woman. She's Canadian and she's Catholic. That information came from right here in the demographic area. Notice I'm in demographics when I click continue or continue. It takes me right back to the work area that I was just at. We're going to take a look at some of these areas here. There's a lot here to explore, probably literally thousands of sentences that you could push in here. I'll show you some of my favorites. Does she have high-risk psychosocial behaviors? Maybe family negativity is present and puts her at risk for noncompliance with mental health services. You could definitely put that in. If, for example, she had suicidal ideation, you might want to talk about whether there's weapons in the home. And she says, oh, yes, we have weapons. My husband likes to hunt, but they're secure. ICANotes says, please provide some additional details. So I'm using a custom button here that says, family states the lethal weapons are under lock and key. And I can put that in as a quote right into the note here. There's some other areas that we can talk about. Let's come down here and talk about, you can move in alphabetical order. I like to talk about relationships and marriage first. I'm going to say that she's been married or partnered once. The current relationship length has been more than 15 years, and the quality of the relationship is, we have everything from problematic, excellent, all the way down to turbulent and chaotic. I'm going to say it's good with a very supportive spouse. If I want to come up here and talk about how many children are in the marriage, I'm going to click here under the heading of everybody. Let's say they have 2 children from the current marriage and there's 1 child who's deceased. Okay. There's some other areas that we can come up here. Coping strengths. We have lots and lots of good options here. I'm going to pick out just one for an example. Let's say she's cognitively bright. I can say she's intelligent, she's verbal, she's got a good attention span, she's artistic, and she has good ego strength. So you have the ability to put in positive attributes for your patient under the social history. Some other areas that you can talk about here is her criminal justice history. I'm just going to say that it's entirely negative. You can talk about her educational history, very simple. I'm going to say she graduated from college with honor. She had no serious behavioral problems at this time. You can talk about her employment history, her family of choice, family of origin, gender or sexual identity. Let's just drill down here to, well, let's take a look at this. Natal sex, and she was born female. How does she currently identify? She identifies as female. And what's her current sexual orientation? And she identifies as straight. Okay. You can talk about her housing, if she's had a military history, what her personal goals might be. Residential status, homeless or in a good house in a safe environment. Substance abuse, if she has a past history of substance abuse, maybe she smoked cannabis in high school, you could capture it right here. Trauma history, maybe she was in an automobile accident. Details are as follows. I could type down that she spent 6 weeks in ICU on a ventilator and has had multiple reconstructive surgeries, so on and so forth. I could also, if I have those type of sentences to add in frequently, I could make custom buttons and just pop those in one at a time. We're going to skip developmental history and come back to this when we're talking about a child patient. This is an adult patient. Let's go over here to family mental health history. And we're going to come down here and remember what she had a sister who Completed suicide, I'm going to say by drowning. I'm going to say that she also has a brother who was hospitalized for bipolar disorder. She has an uncle who was treated as an outpatient for bipolar disorder. This was on the paternal side of the family. She also has a cousin who was carries a diagnosis of bipolar disorder, also on the paternal side of the family. Notice we're getting some very specific information about bipolar disorder on the paternal side of the family. And I'm going to come down here and say, but otherwise, the family psychiatric history is negative. Okay, let's go over here to the mental status exam. In the mental status exam for prescribers, you can pick up 11 bullet points very easily. This is the third area where evaluation and management coding is going to be important. Let's just stop for a minute and review what we're talking about again, just strictly in terms of E&M coding and the algorithm catching information for you. We got some information on anxiety and depression, and we got 5 bullet points right here. We decided that the level of her medical complexity was moderate. This is the physician or prescriber's call. If you want to know how CMS defines those low, medium, or high areas, you can click on the little question mark here and read that. We did a problem pertinent review of systems, and we skipped down here and we did a detailed review of other body systems. We've come across all of our history areas, and we're now in the mental status exam. The program is going to want you as a prescriber to capture 11 bullet points sort of for maximum examination of the patient and for maximum coding credit. We're going to come over here and start with appearance. Please do not use the normal mental status exam button because it will tend to down code you, and you probably don't want to do that. We're going to start with appearance, and I'm going to say this patient, I'm going to talk about my depressed patient here. She's glum, she's irritable, she's disheveled, and she looks unhappy. Her speech and language are both normal. If they weren't, I could go into the C list. Her mood is not elevated or euthymic. She's depressed. It's moderate. She's tearful, she has psychomotor retardation, she looks sad, she denies suicidality. We're going to go back to our mental status exam. Notice you're getting a red X in every area that you work in. Her affect isn't normal. Let's come in here and take a look at some of our options. I'm going to say her affect is blunted. And I'm going to also use a custom button that says Snow stares down at the floor during the entire interview. So just a little extra detail that I can put in. Let's go back. By the way, the back button is almost always on the upper left-hand side here when you're moving back to a prior page. Associations are normal. This patient is not psychotic. If you click not psychotic, you're going to get a nice paragraph here saying no apparent signs of hallucinations, delusions, bizarre behaviors, or indications of a psychotic process, etc. I do want to take you in here and show you the psychosis C list, just so that you've had a look at this. If psychosis or borderline psychosis is present, the program will put in this nice sentence: psychotic or borderline psychotic symptoms seem to be present today. Okay, you can talk about unusual behaviors, hallucinations, inappropriate affects, delusional thoughts, and associations, everything from intact to word salad or just plain untestable. Our young lady here, Snow, is not psychotic. I'm going to go ahead and erase this sentence, right click, and just cut it out. We're going to go back. And I'm going to say she denies suicidality, she denies being homicidal. Cognition, I'm going to say, is normal. If your patient is disoriented, has cognitive problems, or has some level of dementia, you can go into the C list. Let's just take a quick look here. You can talk about the level of severity. Can she do a simple calculation? Does she know who Barack Obama is? Can she explain a simple proverb in a way that's not concrete? Is she indeed oriented times 4 or not? And you need to break that down. Are there word retrieval problems, memory loss, periods of confusion? Maybe she's sundowning at night. What's her level of consciousness today when you interview her? It can be anything from alert to intoxicated. Let's go back. And I skipped over this area here. This is the mini mental status exam. I'm going to let you psychiatrists come in here and play in this area. These are some of the tests that you do with your patients, and they're kind of fun to look at, and they're well mapped out in ICANotes. They're here at your disposal if you'd like to use them. All right, let's come down and look at IQ. I'm looking at this as IQ baseline, above average. NI stands for normal, intelligent, borderline, or disabled. I'm going to say she's normal, intelligent. Insight into illness, good, fair, or poor. I'm going to say hers is fair, and her social judgment is all. Actually, I'm going to say her social judgment is good. I made a mistake. I'm going to erase that. Okay, no problems. I'm going to say that it's good because even though she's pretty depressed, she brought herself in to see you right away. She realizes she's getting into trouble. That shows good judgment. Anxiety, I'm going to say, yeah, she did have some anxiety. We can look at that list again if we want to. And what are you observing as the clinician? You're seeing that startle response that she told you about. We'll get right back out of here. Okay. Her attention span, I'm going to say right now that it's normal. Her behavior is demonstrates poor eye contact. She's not withdrawing from drugs or alcohol. You have the ability to do a physical exam if you need to. You can do an AIMS exam if you need to. You can capture vital signs in the outpatient setting if you would like to. You can also do a musculoskeletal exam. I will take you into the vital signs in the event that you capture that in your outpatient setting. I've made a custom button here for vital signs. And I do that just because it separates my vital signs from my mental status exam, makes it a little bit easier to read my compiled note. Anything that's documented in the constitutional exam, anything in here at all, will be captured here. And when you compile your note, will show in the log area, so you can trend this individual data over time. So you can do a supine, sitting, or upright blood pressure, systolic, diastolic, and associated pulse. Let's do a sitting blood pressure. Let's say maybe she's a little hypertensive, 162, and let's say her diastolic's not too bad. It's 84. And her associated pulse rate is, maybe she's a little tachycardic at 92. She's probably a little tense. And the regularity is regular. Her respiratory rate is up here at 17. She doesn't have a fever. She's 98 plus. If you do pulse oximetry, you can capture that. If you need to capture a height, weight, and BMI, it's really simple. Click in here. For the adult, we start at 5 feet. Let's say this lady is 5 feet 8 inches tall and she weighs 145 pounds. All I have to do is click in here to the BMI, and it shows me that 22, she has a normal BMI. I can capture waist circumference, fasting glucose. We'll just capture this. Maybe she was right at 100 today. And maybe she has 1+ peripheral edema. Okay, I'm going to go ahead and click Done. This information has now been captured in your note, and it's going to push out into the log area as well. Let's go over here. We're almost done with this note. We're going to go into the finish initial. Okay. And we're going to skip the medication area right now. I'm going to take you through the medication workflow in a different training video, probably the one that will follow this. Let's come down here and look at instructions, recommendations, and plans. We have custom buttons here that work in this area. This whole area here can be blown up. See more instructions. Okay, so I'm going to work on the left side here and talk about her disposition. Right now I'm seeing her in a clinic or an outpatient setting, or if I was in an IOP setting or a partial hospitalization setting, I could pop that in here. What am I going to be doing for this patient today? Probably offering some crisis-focused therapy. No doubt I'll be doing some psychopharmacology. And I have lots of custom buttons that I can use. And I'm going to come down here and say that you spoke to the patient about the risks and benefits of medication, even though we didn't document medication yet. Okay? We'll come back. All right. As prescribing clinicians, you can skip the start and stop time. E&M notes are not time-based. They're based on the level of detail that you document under the history of present illness, the level of medical complexity, and the number of bullet points, and the level of detail that you put in the mental status exam. That doesn't mean that you cannot do this, but you are not obligated to do this. When we look at a psychotherapy note moving forward, that will be time-based, but we're not going to do that in this initial assessment. Notice that the medical history shows over here. Pink fields and ICANotes are important fields. This entire medical history has been pushed over here. We're in our Finish Initial tab. Here it is. The entire medical history will print out in the initial assessment for any clinician, doctor, nurse, or social worker. It'll also show up on all clinicians' daily progress notes. You'll have the option as to whether you want to include that with your note or just leave it inside here and refer to it. This is a nice feature. You don't have to go back into prior complete evaluation to find out what the medical history. We also have an area called Notes and Risk Factors. The program is automatically pushed out for us because we've clicked using buttons. This patient has been assaultive. There's a history of medication noncompliance. I'm going to add a detail. History of cutting if anxious. And just to make this really pop for us, you can actually turn this red. And I'm going to make this bold. And you'll see why in just a minute. Style. Bold. Here we go. Okay, we have a suicide and violence risk assessment. I'm not doing a therapy note right now. I'm going to erase this header. Some fields in the program share documentation areas. I'm looking at the suicide and violence risk assessment. I'm in the outpatient setting. Is there a history of risk factors? As a matter of fact, she had a suicidal family member who completed suicide. So this automatically puts her at higher risk than somebody that doesn't have that family history. What are her current risk factors? I'm going to say she's got a little bit of anxiety. She's got major depression. She feels hopeless. And she's suffered a significant recent loss. I don't see twin sister here, but we know what that's referring to. What protective factors are in place? I'm going to say her responsibility to her children, her therapeutic relationship to you. Therefore, I can say the risk of suicide is probably, I'm going to put down low, mainly because of her sister committing suicide. It's not absent or very low. We want to keep an eye on her. And the risk of violence, I'm going to say, is also, because I put down that she cuts sometimes, I'm going to put this at moderate until I have ascertained, how much cutting she actually does. Let's go back to our work area. The suicide and violence risk assessment shows up in this field. We are almost done. We're going to come up here to the diagnosis, and we're going to come over here to the ICD-10 diagnosis. And you should all be working in ICD-10, either searching for your diagnosis or putting in a code, an ICD-10 code by diagnoses. And I'm going to put in here F32.2. When I click over here, it says major depressive disorder, single episode, severe, without psychotic features. And that sounds like our Snow White today. You can put in additional diagnoses. If you don't know the number, the code number, come over here to the ICD-10 tab. We're just going to work across these three drop-down menus. It's not hard. Let me blow this up so you can see it pretty easily. I'm sure by now you're all getting used to ICD-10. The F codes for behavioral health are right here, F1 through 99, mental, behavioral, and neurodevelopmental disorders. If she had an anxiety disorder, it would be under F40 through 48. If she had an affective disorder, it would be above here, schizophrenia, psychoactive substance abuse, so on and so forth. But we're going to come over here under anxiety disorder. And it looks like we have a lot of choices here. Let me see what I'm going to put down. I have so many choices. I'm going to put down anxiety disorder unspecified for right now. You could also put down medical diagnoses. You can add as many diagnoses here as you need to. You can rearrange the order of them. If you wanted to make one of your diagnoses a rule out, let's make this anxiety disorder a rule out. You can put an X right here. We'll click done. You can see that it says rule out. I'm going to take this down from 150% in the lower left-hand corner down to 100%. It's just a little bit easier to work if you can see the entire field. Okay, we're going to go ahead and code this note. And I'm going to come in here. We're going to get an evaluation and management code. This is for a new patient in the outpatient setting. Let's see what kind of code is generated for us. We have earned a 99203A1. If you have any questions as to how you generated this particular code, you can go into the evaluation and management coding matrix. We'll talk more about this in a subsequent video. But here's our code down here, and here's the area under the history of present illness, under your mental status exam, and under your medical decision making. And the program has told you that this is the highest code that you can bill for based on the level of documentation that you've done. Let's go back to the work area. And I'm done here. And if I want to, we won't talk about justification for level of care right now. Here's the follow-up button. If you want to talk about when you're going to be seeing your patient next, come over here to number 7, and maybe you'll be seeing her in 1 week or earlier if needed. I'm now ready to compile my note. Anytime you do a complete evaluation, the program's going to ask you to put a heading on it. You can say, and there's a couple of options you have here. I can say this is a complete evaluation, and then I'm working in the outpatient setting, and then I'm a psychiatrist. Or I could come down here and say, instead of just saying generic psychiatrist, I could come down here and say, put down the name of my practice, for example. And I could come down here and say, this was done by Liz Lobeo, MD. So there's a couple of different options that you have here, in addition to the options that we give you right up here. Let's click continue. Okay. Here's, whoops, the program that wait for just a second, because every note created in ICANotes is saved as a PDF. The program just took a snapshot of that picture. For that reason, if you read here, please do not alter anything on the compiled note. It will not save if you go back into the work area and have to recompile the note. Now, I'm not talking about small formatting issues. See if I can find something here. For example, if I wanted to get rid of this space, this is fine, no problem here. But I wouldn't change your allergy status right here. I would go back into the program, or I could come down here and just close this gap here a little bit if I'd like to. So here's your complete evaluation. If you were to print it off, it would be about 2.5 pages in a size 12 font. You can see that it's clean and easy to read, uses the patient's proper name, pronoun, possessive pronoun. Got all of our good information in here. And I have a signature line here for the doctor who created this note. However, this note is not a legal document until I either print it out and sign it with a pen, or that's the old-fashioned way, but if you're using paper in your office, you can certainly do that. Or if you electronically sign the note. Let's look at the e-signature field right here. This note has never been electronically signed. This icon is gray. To electronically sign it is very simple. You just click the button. E-signature will be turned on for you if you're saving your notes on our servers. Let's scroll down here, and you can see what the e-signature looks like, electronically signed by the doctor on this date and time. It gives you a time right down to the second when you electronically sign this. This timestamp right here matches this timestamp right here. The green check mark means that we're signed and locked, and it also matches this timestamp here, telling us that we have one signed and locked record, complete evaluation for snow on this date and time that's signed and locked. Now, Let's come over here and say we're scanning this after we've signed it, and I say, oh my goodness, I put down that she has a history of cutting when anxious, and that's a mistake. I don't want to correct that here. That's the wrong workflow. I can always go back into the workflow. Green buttons, green, green, and green means that you have access to these work areas. So even though I've signed and locked this note because this is a legal document belonging to this physician, Dr. Liz can always go back in here and can go back into any portion of the note and and update the information on it. Luckily, my error is right here under Notes and Risk Factors, and I'm going to erase anxious because she told me she has a history of cutting if depressed. Okay, I'm going to recompile the note. Very important. It's going to turn white for a second. The program took a new snapshot of it. This is your new note. We're no longer electronically signed in. When you look at the e-signature work area right here, you see the red X. This note was modified since it was e-signed. I can see that I corrected it. I'm happy with the note. I'm now going to electronically sign it and lock it again. The note is now electronically signed. Just to prove it, we can come down here. There you go. And we're all done. I'm going to come back up and we can go back to the chart face. And you can see here now that we have a complete evaluation in the outpatient setting, psychiatric clinic that was electronically signed by Liz MD on 12/14/2015.